Good morning, everybody. Today we will deal with the nasal septum and some of its disorders. All of you know that the nasal septum is divided into columnar septum, membranous septum, and septum proper. And again, in the septum proper, there is a cartilaginous septum and the bony septum. And there is it is formed by a quadrangular septal cartilage and bones like perpendicular plate of ethmoid, vomer, and in the front nasal spine of the frontal bone will be there, and down in the palatine bone there is a nasal crest of palatine bone will be there, and behind there is a rostrum of the sphenoid bone. So this thing anatomy part you know very well, and some of the disorders of the nasal septum are commonly deviated nasal septum. So now we will go little in detail with the deviated nasal septum. So what are the etiologies for the deviated nasal septum? Is one is a trauma. Trauma is something like a blow on the nose or a history of fall, especially during childhood or while playing, and developmental abnormal, like while giving birth there is a molding of the face, like when during delivery that time, and there is a congenital high arched palate or unequal growth between skull base and the palate, and sometimes there is a mass in the one nasal cavity will push the nasal septum to the opposite side. So there is a unilateral deviated nasal septum because of the mass on the other side, and some racial factors like especially it is commonly found in the Europeans deviated nasal septum, and hereditary, usually in the family it runs, especially seen in the posterior part of the septum is deviated. So there are types of the deviated nasal septums. One is anterior or caudal dislocation, and C-shaped deformity, S-shaped deformity, and septal spur. It is like a shelf-like projection. Especially found, it is a sharp self-like projection, especially found in the bony cartilaginous junction. And there is a thickening, sometimes there is a septal thickening because of the organized hematoma or overriding of the septal fragments or duplication of the septum, and impacted septum. Despite there is a decongestion, even though there is no relief for the nasal obstruction when the impacted septum is there, it is pressing upon the other structures. So some of the pictures of the like anterior or caudal dislocation you can see from anteriorly. When you raise the tip of this the nose, you can see the anterior or caudal dislocation, and C-shaped deformity you can see with the anterior rhinoscopy, and S-shaped deformity you can see either above down, S-shaped deformity, or from front to behind, like that you can see. And you can see the picture of a septal spur here. See how it is compressing on the lateral wall, the sharp structure, self-like projection, and thickened and impacted nasal septum. You can see here thickened septum, which is very thick and causing obstruction, and other one is a impacted nasal septum impacting on the other structure on the lateral wall of the nose. So here the another picture you can see the C-shaped DNS, which is not touching the lateral nasal wall. So which is not touching the lateral nasal wall is third grade, and it is not very severe. And then C-shaped DNS touching the lateral nasal wall, it is comes in the fourth grade. So severity of at least one side complete obstruction will be there. Severity of the symptoms will be more. Similarly, what will happen here? Here is one side deviated nasal septum. The other side there is a slowly compensatory turbinate hypertrophy. When the place becomes more roomy, to compensate that, turbinate will become hypertrophy, and eventually patient will get both side nasal obstruction, like that. And what are the common clinical features or symptoms when the patient present is nasal block, obviously because of the obstruction, usually present on the deviated side of the nasal septum, and contralaterally sometimes paradoxical nasal obstruction due to the compensatory inferior turbinate hypertrophy. So because of the turbinate hypertrophy on the other side, so it may become paradoxical nasal obstruction on the other side. So initially patient will be having nasal block on one side, and later on patient will complain on the other side. But actually when you say DNS is on the one side, but the patient doesn't have symptoms that side, because he will notice only when the other side paradoxical hypertrophy of the inferior turbinate is present. That time he will have the more symptoms. Maybe recurrent cold due to associated sinusitis due to obstruction to the drainage of the secretions, and headache due to contact with the lateral wall sometimes. This is called Sluder's neuralgia or anterior rhythmoidal nerve syndrome, and also due to sinusitis, due to stagnation of secretions in the sinuses, there is a chance of sinus headache. Other clinical features, like more severe features like epistaxis due to stretched mucosa on the deviated nasal septum, dry crusting of the dry crusts, and bleeding of the like when you remove the dry crust, there is a bleeding on the removal of those crust, and stretched blood vessels over the spur that may cause the recurrent epistaxis from the same area. And hyposmia is seen in high deviated nasal septum. Usually like deviated mild deviated septum, it doesn't cause any hypoxia, but in severe or gross deviated nasal septums, the patient may complain of hyposmia. And there is also chances of external nose deformities along with the internal like obstruction. Some very few people will come with the external nose deformities. Maybe simultaneously you will find internal also there is a deviated nasal septum. So what are the sequelae? If you doesn't treat these, the patient may go for the sinusitis. It may become initially acute sinusitis with headache, cold, cough, nasal obstruction, throat pain. Then later it will become chronic sinusitis like that, and patient may be having a mouth breathing causing like snoring may be the history, and sometimes pharyngitis due to dryness, mouth breathing will be there. And atrophic rhinitis, sometimes unilateral gross deviation will cause one side roomy space, and patient will have the suffer from the atrophic rhinitis. Foul smelling crusts will be there. Because of that, the masses, the houseflies may get attracted due to that foul smell and lay eggs, and then these will hatch to become the maggots. So that so the complication or sequelae. And otitis media due to like secretions due to sinusitis, chronic sinusitis, the infection may spread through eustachian tube to the middle ear. So in children it is quite common. You have to look for whenever ear case, otitis media case comes, nose, you have to see. So you will go for the like a treatment part. Before, usually surgery is the treatment. Medical management is very limited in case of gross or very minimal deviated septums. You can use the decongestions like xylometazoline or oxymetazoline in nasal drop, decongestant nasal drops, and some antihistaminics and decongestants orally also can help. Some sprays of antihistaminics, steroid sprays, especially if associated with allergy, you can use. But otherwise, usually septal surgery is the treatment. So some history about the septal surgeries, you can see 17th century BC, Edwin Smith surgical papyrus. There is a book, textbook written in ancient Egyptian textbook on trauma in 3500 BC, and some 48 traumatic injury cases are listed. Along with that, even treatment of DNS, that is a fracture reduction of deviated nasal septum with internal pack using grease coated linen and external packing with the stiff rolls of linen is written in this Edwin Smith papyrus. And similarly, some operations are described in late 19th century, like Bosworth operation. Deviated part of the septum is amputated along with the mucosa, and Ash described in 1999, full thickness cruciate incisions on septal cartilage. Frears in 1902 described SMR of total septal cartilage. Killian modified it in 1904, SMR with preservation of dorsal and caudal portion of septal cartilage. And similarly, like other surgeries were described. Here, Quartle's line, like one Quartle, he described premaxilla septoplasty. He also described Quartle's line. I will tell you in the later slide. And this is a picture of Gusto Killian, what we call now Killian's incision and SMR surgery. And this is a picture of Maurice Cottle, who described this maxilla and premaxilla septoplasty. Also, he described on Cottle's line. I'll just explain in the next slide. The indications for the septal surgeries are like deviated nasal septum causing the nasal obstruction, or it may be leading for complications like sinusitis or frequent headaches or frequent epistaxis, and sometimes along with the rhinoplasty, that we call it as a septorhinoplasty, and harvesting of septal cartilage graft. So to get the cartilage from the for the rhinoplasty, we may sometimes harvest by doing the SMR. And transseptal surgeries like hypophysectomy, Vedian neurectomy, and hereditary telangiectasia, that also we can treat with doing the surgeries. So septoplasty, you can give the Freer's incision here, just anterior to the septum. And there is a line I was telling, that Quartle's line. It is drawn from the frontal spine to anterior nasal spine, and deviations anterior to it can be treated by septoplasty only, and posterior to it by SMR or septoplasty. So you can see the Quartle's line. And in the septoplasty, mucopericondyal flap elevation on one side, and anterior and inferior tunnels are made here, and inferior cartilage strip, you can cut it and remove it, and dislocation of bony cartilaginous junction, and mucoperiosteal flap. You can do the mucoperiosteal flap elevation on both sides, you can do, and cartilage and bone are removed from the, you can see the picture, where the cartilage and the bone are removed, and scoring and cross hatching of the nasal septum, that is the cartilage part, is done, and then wedge excision or sometimes shaving can be done to straighten the nasal septum, and anterior nasal packing is done either anteroposteriorly, above below or below above, and outer nasal packing, you can see the plasters are applied, and usually after 48 hours it is been removed. And submucosal resection surgery, you can put the Killian's incision here. So little Killian's incision is a little behind compared to the Freer's incision, and unilaterally slightly curvilinear incision 2 to 3 millimeter above the caudal margin of the septum, just passes the mucocutaneous junction on the concave side, usually it is done, and mucopericondyal flap elevation on the right side is done. Cutting of the cartilage and elevation of the opposite flap, like you have to go through and through to the cartilage and then elevate the opposite flap, and then the deviated part of the septal cartilage is been removed, and you can see the picture where the caudal and dorsal struts are kept this thing, and its other part of the deviated septum is been removed, and the cartilaginous and bone part is removed, and then anterior nasal packing has been done. and this pack can be removed after 48 hours, and along with that you have to give some antibiotics and also analgesics, and you should observe post-operatively patient for any fall of the tongue and breathing, that you have to monitor the patient in ICU. So what are the difference between the SMR and septoplasty is, SMR is a radical surgery and septoplasty is a conservative surgery, and SMR is usually not done below 17 years, and septoplasty can be done after 4 years, and usually Killian's incision is given in the SMR and freer incision used in septoplasty, and in the SMR we cannot correct the anterior deviated septum, and in septoplasty you can correct the caudal dislocation or anterior septal deviation, and in the SMR surgery bilateral mucoperichondrium is elevated, but in septoplasty only one side you will elevate, and in SMR radical removal of the cartilage is done, and in septoplasty only inferior strip is removed, and in the SMR rhinoplasty incision cannot be combined, whereas in septoplasty it can be combined, and revision surgery is difficult in SMR, and septoplasty relatively easy, that's why we use it below 17 years, because any other deviation again we can recorrect it, and cartilage graft can be harvested in SMR surgery, but it cannot be harvested in the septoplasty operation, and complications are very common in SMR because both side elevation is done, and in rare in septoplasty. Complications of septal surgery, there is a hemorrhage, septal hematoma, septal abscess, septal perforation, saddle nose deformity, columellar retraction, flapping of the septum, persistent deviation, nasal synechia, CSF rhinorrhea, infection, toxic shock syndrome, and other some of the common disorders you can see in the septum is septal hematoma collection, which is a collection of blood under perichondrium and periosteum of the nasal septum. The etiology is trauma, septal surgery, and bleeding disorders. Clinical features are like bilateral nasal obstruction, sense of pressure over the nasal bridge, bilateral smooth rounded septal swelling. On palpation, mass is soft and fluctuant, and absence of raised temperature, erythema, swelling, and tenderness over the nose. Because if the presence of temperature and is there, this hematoma is getting infected and then converting into going for the septal abscess. So this is a picture of the septal hematoma. Treatment is if it is a small septal hematoma, wide bore needle aspiration can be done, and if it is a large, incision and drainage and nasal packing to prevent the recurrence, and systemic antibiotics can be given. Complications are like thickened septum can happen, and septal abscess with cartilage necrosis, saddle nose deformity, supraoptic deformity, septal perforation. All these are complications of septal hematoma. So again, septal abscess is a collection of pus under perichondrium and periosteum of the nasal septum. Etiology is a secondary infection of septal hematoma following usually furuncle or of the nose or upper lip, and following typhoid or measles. And clinical features will be bilateral nasal obstruction with fever. That is a very important feature. Skin over the nose shows raised temperature, erythema, swelling, and tenderness. It is bilaterally smooth, soft, fluctuant septal swelling, and septal mucosa is congested. Submandibular node may be enlarged, and it is tender. So now we can see the picture of the septal abscess and also CT scan of the septal abscess. So treatment of the septal abscess is drained immediately, and incision made on the most dependent part, and pus and necrosed cartilage is removed, and nasal packing is done, and systemic antibiotics for 1 week to 10 days you can give. And complications like you can expect necrosis of the septal cartilage, saddle nose deformity, supratip deformity, septal perforation, meningitis, cavernous sinus thrombosis, all these things. And post-operatively even you can see nasal synechia. So, and perforated nasal septum, these are common. Perforated septum is very common in SMR surgery. So etiology of the uh, uh, perforated nasal septum. So trauma in that septal surgery is the commonest, and nose packing, septal cautery, ornamentation. Sometimes they use ornaments in the septum, and infection like septal abscess, using of snuff and cocaine. So these are all nasal irritants, and foreign bodies, rhinolith, nasal myiasis, granuloma diseases like TB, leprosy, syphilis, and vaginous granulomatosis, malignancies, and idiopathic. These are the etiology for the perforated nasal septum. Clinical features: if it is a small perforation, whistling sound during respiration, that is quite a prominent feature. And the large perforations, there will be crusting, there is maybe obstruction and epistaxis on the crust removal. So perforated nasal septum picture you can see, and treatment is usually you have to treat the cause, like cocaine. They are using some cocaine, snuff, those all things you have to avoid. And if it is a secondary to some granulomatous disorders, you have to treat. And alkaline nasal douching to remove the crust. And if it is a small perforation, it may be closed by mucosal advancement flaps. And large perforation like celastic obturator, alloderm, and the results of the surgery are usually poor, but you can try some obturators like things. So these are all the pictures showing the how the mucosal flaps are taken. Even sublabial flap you can put, and celastic obturator you can put in the required size. You can select required size obturator, and you can put it in the septal perforation. So these are the common disorders of the nasal septum, and thank you very much for your patient hearing.